everybody. Welcome to the Enovis webinar, ACL Injury, Can a Non-Coper Become a Coper? Today, the speaker is Professor Jim Richards, Professor of Biomechanics from the University of Central Lancashire. Professor Richards is the Director of Research for the Faculty of Allied Health and Wellbeing, Professor of Biomechanics, Associate Dean for Research and Knowledge Exchange, School of Health, Social Work, and Sports. He is also the chair of the Motor Control Technical Group of International Society of Biomechanics. And today, Q&A session, we will also have Jimmy Reynolds. He's a chartered physiotherapist from Alpha Physiotherapy in the UK. So please stay with us until the Q&A. And this webinar is pending CPT points of Hong Kong Physiotherapy Association. So please stay until the end to scan the QR code to attend the attendance certificate for the CPT point. Enovis also has an online certification platform, which is called the Learn Up On, where you can do online courses about ACL injury and physical modalities, and to gain the certificates. So again, stay with us until the end for the link of the Learn Up On. And before the presentation today, since we have a very large group, we are very happy that today we have more than 350 registration from more than 30 countries. So we thought that it would be interesting for us to have a poll question on this topic just before the webinar. So the first poll question is, ACL injury can be categorized as a coper and non-coper. Potential copers are characterized as having good knee stability and can return to previous injury level without surgery, whereas non-coper cannot. So the first poll question is, in your practice, what is the estimated percentage of ACL injury coper versus non-coper? So we have half a minute for the question. So if you click on the chat room, you'll be able to see the poll question and select the answers. Okay, maybe we give 10 more seconds. So what is the percentage of coper versus non-coper in your practice? So we've seen that 60% coper versus 40% non-coper seem to be has the highest poll. Okay, interesting. And then the second question, also very related to today's topic, second poll question. So it's about kinesiophobia. One of the ACL injury return to sport criteria is psychological readiness, according to AOS 2019 guideline. So do you measure kinesiophobia or psychological readiness after ACL rehabilitation for return to sport? The selection is yes, always, yes for selected athlete, or no. Please make your choice. Okay, we give 10 more seconds. Okay, very interesting. For selected athlete and no seem to have very similar percentage. Okay, so then let's see what Professor Jim Richards has to say regarding coper, non-coper, and return to sport. So welcome, Professor Richards. Thank you.
I have a presentation of about 45 minutes to talk through some of the work that we are doing around ACL injury, in particular the consideration of copers and non-copers after ACL injury. So obviously we know that the risk factors associated with ACL injury are landing with a substantial amount of knee valgus, with high ground reaction forces. So we've known this for many, many years. And it's advised that we should do cutting maneuvers, cutting tasks, sidestep tasks with less flexion and greater knee valgus. So, these are all these major risk factors. So if we have less knee flexion, greater knee valgus, then we're going to be at high risk of injury. So if we look at the advice that we sometimes give, or that is produced within the literature, when landing, athletes should avoid extreme toe-out foot rotations to minimize the undesirable knee valgus loading. And that sounds fine, we have this advice, but how on earth does somebody who is doing elite sport actually do that? Because if you're getting them to start thinking about their movement, you'll actually make their movement worse. So this is from a paper in 2017. So it's a fair statement, but the question is, can we do this? Can we achieve this whilst moving unconsciously rather than consciously? And I'll come back to conscious and unconscious movements. So this is an ACL injury which happened at the 2011 World Cup with quadricep, playing against the Welsh there, and that's an ACL injury. So that had him out of playing rugby for around about 9 months, that tiny little event. So what we can see is immediately after injury, Quade was put into a full-length knee brace. And the thing I want you to notice here is the knee brace is set into flexion. Slight flexion, and there's a reason for that. We'll come on to that shortly. Now, of course, within the environment we're here, we want to talk about surgery as well, and we're going to think about surgery, and can surgery bring back normal function? Well, surgery can give us the structural integrity of the ACL, but that's not function. And it's been well published these days that ACL injured and ACL reconstructed individuals show altered biomechanics. And they show altered biomechanics on both the injured and the uninjured limb. So if you injure one side, there's biomechanical changes on both limbs. So what's going on there? Well, the ACL isn't just mechanical, of course. It is a very, very important mechanoreceptor. So we have information coming from the ACL going to the brain. The brain then uses that information in terms of the control and positioning of the foot, which then allows the person to place their foot. Once we've removed the ACL on one side, or it's ruptured, and we've lost that nerve supply, the brain hates asymmetry. So the brain is now going to filter out the information from both ACLs, from both sets of mechanoreceptors, causing poor biomechanics on both sides. So we end up with poor biomechanics regardless of how good the surgery is. So surgery does not bring back normal function. It might bring back the structural integrity. But let's have a look at this structural integrity. This is a picture from a very, very long time ago, but this still remains true today. But at the point where a graft is implanted, we get 100% strength. We then have a quick drop-off of the strength of the graft. And this is, we get revascularization, deorganization of collagen, and then slowly we get the revascularization and the reorganization of collagen. The point is that if you take this to the end point, after 36 weeks post-op in this case, we've reached 50% strength of the original graft. Bearing in mind this athlete has ruptured something which was 100% in the first place. So we have an imperfect solution, and it's as good as we can do with surgery without having the full reconstruction of all the vascularity and everything else, and that's almost impossible to do with today's techniques. What about when do we send people back to play? Now, I would recommend anybody that's interested in rehabilitation programs, responders and non-responders, copers and non-copers, to read pretty much everything that Lynn Snyder-Macker has ever published. Lynn is fantastic. She has spent her lifetime looking at physical therapy, physiotherapy with ACL recovery. So she has a whole array of many, many papers. In particular, Lynn was instrumental in setting up the Oslo, Delaware set of studies. And this is a longitudinal data set, and they have produced many, many papers. So I would strongly advise, if you are not aware of the Delaware, Oslo, or Oslo, Delaware studies, to read up on everything that you can find on the Oslo, Delaware studies, because you have a substantial cohort of data. So basically, what has come out of some of the work from the Delaware Oslo is in the first 2 years after ACL, 30% of people who return to level 1 sports sustained a re-injury. 30% have got re-injured. Why have they got re-injured? Well, it might be that the graft strength has never reached its full strength. Or it might be that there was neuromuscular changes in their movement, which means that they are then positioning themselves, or their foot position is wrong, and they end up with a re-injury. So we're now going to deal with the concept of copers versus non-copers. Currently, there's no way of fully classifying copers and non-copers from when the injury has first occurred. So when an injury occurs and we first see the patient, we can't determine at that time point whether they're going to be copers or non-copers, unfortunately. There's a lot of work going on looking at subgrouping. There's a lot of work going on looking at responders and non-responders. But potential copers are characterized as having good knee stability, whereas non-copers have poor stability. Copers are generally active individuals, and they have good hamstring activation after the ACL injury. So hamstring is obviously really key, because it's going to stop that movement into extension, hyperextension of the knee. That's when the ACL is under its greatest load. So good hamstrings is absolutely critical. We often think about quadriceps, but hamstrings is the thing which is going to stop that re-extension. What makes a non-coper? Well, non-copers are intuitively trying to protect their knee. So we can recognize these people because they usually have a lot of quadriceps avoidance. They are walking like they're protecting something. So they are highly likely to be our non-copers. And why do they walk like this? Well, it's not due to any functional deficit usually. It's due to high levels of kinesiophobia, fear of movement. So kinesiophobia is an absolutely critical aspect of these kind of concepts. So I guess the key thing with this, with the non-copers, because the non-copers are the ones who aren't going to progress back to the sports they're wanting to do, the activity levels, and they're the ones that are of greatest concern to us. So can we help the non-copers to become copers? Okay, so one of the things that we need to think about is different ways that we can manage. And one thing we can do to manage the forces around the knee is with knee bracing or knee orthoses. So there's been a lot written about knee bracing and ACL recovery, and the whole purpose of a knee brace, such as this one here, so the whole purpose of this knee brace is to stop the anterior translation of the tibia, or the posterior movement of the femur, if you will. So it's that translational movement of the knee. So this is very, very different from the knee osteoarthritis brace. This is to stop translation, not rotation. So this is, we're wanting lovely free rotation, that's fine. What we're trying to do is to prevent the anterior-posterior translation. So one treatment is ACL bracing that we can use, and ACL braces are sometimes confused with other types of braces, valgus, knee bracing, and osteoarthritis. These are entirely different in their mechanisms. So do not think that any brace, chuck any brace on and you'll get a good result for ACL. You won't. Likewise, if you have osteoarthritis and you give an ACL brace, again, you'll have poor recovery. So the theoretical action of ACL bracing goes something along the lines of this. So can we get a play? There we go. So we have our anterior translation or posterior movement of the femur, and we're trying to prevent that with our bracing situation here, with these the various straps that we have on this brace that we do up in a set order. And we have some nice numbers on these braces to tell you what order to do them up in. So the bracing itself, we are trying to put a system of forces to protect the graft, to stop that anterior translation, which is going to put the graft under load. So for early rehab, for early recovery, when we're trying to protect the graft, especially when it's going down in strength, then the knee bracing will prevent any early ruptures of the ACL. It's interesting now, there's more and more evidence coming out on the use of knee bracing in the management of ACL. This is a paper, Orthopedic Journal of Sports Medicine in 2019, which looked at the risk of secondary ACL injuries in adolescents after reconstruction. And what you are seeing here is that those that were wearing a knee brace had substantially less ACL injuries or re-injuries than those that did not wear a knee brace. So the conclusions of this particular paper is that the use of functional bracing can reduce the risk of graft retears. So obviously that's the worst possible scenario, is having a retear. So in this case, that all sounds very positive, but there's more to it than this. We are protecting the graft, yes, but what else are we doing when we're wearing a knee brace? Now, most of these knee braces, when you first set them, because the person, if they move into full extension, the ACL is under the greatest load, we usually set these to slightly flexed. And we can do this by changing the stops in here. So you are ending up with the person being slightly flexed. Why do we want to do that? Well, we're wanting to do that because we're actually going to change the way the muscles are going to work. We're going to, if the knee is slightly flexed, we're going to have some more quadriceps, but we're also going to perhaps look at the different loads because of the sensations of the brace. And these have also been shown to change the hamstring activity as well. So this is a very old paper, but it was the first paper really to look at the EMG alongside all the biomechanics. And what Threat and Lamontagna found was that muscle activity showed an increase in hamstring activity when wearing the brace. So the brace is not just providing this translational stability, it's also changing muscle function. Okay, so that's our hamstrings, thinking about our hamstrings and trying to get our hamstrings active. Now, the point of this paper really was highlighting that bracing is not just mechanical, there's also a proprioceptive element to it. So when you are putting a brace on, your skin around your knees, feeling the various loads, so you know when your tibia is coming forward, but all of this is happening in the unconscious part of the brain. So can we use this whole idea of a knee extension resist or reducing the amount of knee extension constraint? Can we use this within rehabilitation? There's now a whole raft of papers, and I'm just going to show one here, that has now looked at using knee bracing to re-educate the gait, re-educate the brain. If we have this set in slight knee flexion, then we're going to encourage the quadriceps to be active as well. And if we're encouraging the quadriceps to be active, we're going to be reducing quadriceps avoidance. If we set this straight, the patient can walk always with a straight knee. So they're going to potentially have quadriceps avoidance. So this work is basically showing that at 1 week, 4 weeks, and 8 weeks, without wearing a device, so they're wearing the brace and then they take the brace off, we see changes in the biomechanics. We see changes in the neuromuscular control. And we see that we get altered low extremity patterns which are transferred to an unbraced condition during stop jumps and side cutting. So a knee extension constraint device could be a useful tool to overcome that quadriceps avoidance, which is one of the factors associated with our non-copers. Okay, so what about later ACL recovery? I mean, you know, you're not going to want to wear one of these forever, are you? So we're going to wear this, you know, to protect that graft early on, to re-educate the brain. But once the person's starting to do more active sports, there's a lot of sports you can't play with a brace like that, rugby being one of them. You're certainly not allowed to play rugby with that. So what happens later on? So we're now thinking about proprioceptive treatments. Now we've done a series of papers looking at the use of, believe it or not, proprioceptive bracing like this in ACL reconstructed patients way after they've returned to sport. Because there's still a high risk of re-injury because of the biomechanics, the neuromuscular control still being altered because you haven't regrown the mechanoreceptor. So you still have that missing piece of the puzzle that the brain doesn't have. So we've done a series of papers, there's a few more actually since these were published, where we've been looking at proprioceptive bracing in people with ACL. So let me just talk you through this particular work. So we had 15 participants between 2 and 10 years post-ACLR. So this is, you know, mostly people what you consider as copers. And we wanted to test them with slow step down, single drop jump, and pivot turn tasks. And we wanted to look at the three-dimensional movement of the knee when wearing this knee brace. What we see is quite interesting, is that during the pivot turn task, which is the most challenging task out of all of these, we see a reduction in the external, internal, and range of motion in the rotation, internal, external rotation ranges of motion. So this is transverse plane knee movement. So how can this soft brace change rotation? I mean, you know, there's no way that that's going to produce the force. So what happens when people are wearing the brace is that there is that sensory input which is going to the sensory cortex. And the sensory cortex talks to the motor cortex, which then changes the movement strategies. And what we're seeing here is that when people are wearing this brace, they are landing with their foot straighter. We haven't told them to land with their foot straighter, but they are now landing with their foot straighter. So landing with their foot straighter, they are now changing their foot position through the input of other aspects of skin sensation through proprioception, kind of to replace the missing piece of the puzzle that we have with no mechanoreceptor in the ACL. The other thing that we see is that the people who were doing these tasks felt it was easier when wearing the knee brace. So if it feels easier and we're seeing greater stability, less rotation, this is potentially reducing the risk factors associated with re-injury. So what we saw in this particular case is that bracing showed a 10% improvement in the transverse plane knee mechanics and participants were reporting that the tasks were easier, and these could be useful in the clinical management of people who have recovered from ACL reconstruction, but perhaps are still having some issues. So is there any other evidence for this proprioceptive effect? Well, there's two papers which I talk about these papers a lot whenever I'm presenting, because I think that they're a fantastic piece of work. Both of these studies looked at the functional magnetic resonance imaging when doing knee extension, flexion extension exercises under fMRI. So they're looking at brain activity now with taping and bracing. So Mike Callahan used this taping technique, a very basic taping technique. Yuri Theis used this bracing technique. So this is called the Fulkerson Triple Advanced Sleeve. Reason they chose this brace is because there's no metal in it, because people get a little bit upset when you take a metal brace into an fMRI machine. And here we got the setup. So we have the knee extension and flexion extension exercises. And what I'm showing you here is the results from using BOLD, so looking at the blood oxygenation levels with no bracing and this is no taping and taping. So this is the effect of the taping, would you believe? These then got sent to somebody who could read an fMRI scan, and people were completely blinded to what we had done, because don't forget, we're using an fMRI machine, which costs around about £600 a go, multiplied by 5. So to look at whether or not £1 of tape works. Okay, so it was quite a challenge to get this study going. So when we send these reports off, we get that the areas of the brain that are associated, that change their activity, were associated with coordination, decision-making, planning of complex coordination, tasks, and unconscious aspects of proprioception. So we know taping and bracing both have this effect. So we know that we're involving the sensory and the motor cortexes. So now we're going to think about this in longer-term rehabilitation. Now, this next study that I'm going to talk about, this was some work that I did with a group of Italian orthopedic surgeons a while back. Really, it was quite interesting. I was at a conference doing a talk a little bit like the one I'm doing now, and this group of orthopedic surgeons came up to me afterwards and said, can we do a randomized control trial on the use of this brace? At which point I had to do a bit of a double take at this point. But you're orthopedic surgeons and you wanted to look at bracing. Yes, okay. So it was really quite an interesting conversation. So they then went ahead and did a randomized control trial. This was on people with severe patellofemoral pain, so not ACL. But we had two groups of patients who were prospectively randomized. One group who had standard rehabilitation and the reaction brace, again this brace. And we had the second group that had no brace with rehabilitation. And we assessed them at 3, 6 and 12 months using Kajala scale and VAS pain scale. We also recorded the time to return to sport. And what we see, Kajala scale, we see pretty much the same recovery on both groups. But when we consider the pain score in this particular instance, then we see at 6 months and 1 year, nearly at 3 months, we see a significant difference with the pain being significantly lower with the brace group. Why is the pain lower in the brace group? Well, if they are doing all their tasks and their knee joints are more stable, they're going to have less pain, which actually means that they can do more rehabilitation. So you actually get a window of opportunity with using a knee brace to do more rehab in your patients. And this was then shown by the number of people that actually then returned to sport. So in the group, in the bracing group, 24 out of the 30 people returned to sport at 6 months. whereas only 14 in the rehabilitation-only group. And they didn't return because of pain levels. So the key here is that bracing on its own isn't necessarily an intervention. What it is, it's an adjunct to rehabilitation. So it gives a window of opportunity. And this is our end result, and this is our end statements here, that knee bracing can be an effective adjunct to reducing pain in individuals with, in this case, anterior knee pain, which is then going to speed up their return to sport. But the reason we get these changes is because they have greater stability. So that also links in, obviously, to ACL. So far we've been thinking very much mechanical mechanical and motor control aspects here. That's been our focus to date. But what is the main barrier? What stops your patients returning to sport? It's not function, it's kinesiophobia. And this is the critical element with our non-copers. Our non-copers have high levels of kinesiophobia. Do you know how to assess kinesiophobia? Anybody here routinely assess kinesiophobia in their patients? Okay. There's a score, it's called the Tampa score. Tampa score for kinesiophobia. 12 questions, takes 2 minutes. I don't know if there's a Malay version. I know there's a Thai version. I actually looked up to see whether there is a Thai. It doesn't help you here. But you know, there are a number of translations of the Tampa score for kinesiophobia. We now use the Tampa score for kinesiophobia in all of our studies. Because if we're getting somebody that's not responding, it might be that they're not responding for other reasons other than mechanical, biomechanical, or even motor control. So the literature would suggest that around about half of the patients that have an ACL reconstruction have sufficient kinesiophobia that they will not return to their previous competitive level of sport or activity. Nothing to do with their function. So function is important, but so is kinesiophobia. So to explore this, we did some work, again a few years back now, with a group in Turkey. And in their sports medicine clinic, quite obviously similar to what we have here, in their sports medicine clinic, they were regularly using this knee brace, because it's just the one that had available. And they also had this rather interesting taping technique, kinesio taping technique. And they wanted to know whether or not the brace and the tape was going to have any effect on any of the outcome measures in people with severe levels of kinesiophobia. So if their kinesiophobia was fine, they had low amounts of kinesiophobia, they're fine, we didn't recruit them. We only recruited the ones with high levels of kinesiophobia. So we looked at Starr's Gaussian balance test, one-leg hop test, isokinetic quad strength, hamstring tests, and also a global rate of scale of self-reported knee function. We always like to have self-report. We never just rely on biomechanical assessment, because we might well see a change in biomechanics and the patient says, no, I don't feel any different whatsoever, and in which case the biomechanics doesn't matter. You know, we've just wasted our time with the biomechanics without having the patient reported side of things. So, and of course, Tampa score for kinesiophobia. So when we looked at the Starr's Gaussian balance test, we saw that there was a significant difference between no intervention with the tape and the brace, both increasing reach distance. So we can reach further with the brace. Now at this point you go, oh yeah, but the brace is restrictive. No, the brace is reducing the fear of movement by giving the feeling of support. So they're able to do more. So this whole concept of bracing causing atrophy really is a misnomer. Bracing doesn't cause atrophy. Inactivity causes atrophy. I was a wonderful example of that during COVID. Sitting on the same chair every day for well over a year, I had a lot of atrophy. Hop tests showed significant increases in distance with taping and bracing compared to no. So we're seeing immediate effects that these people can do more. Now, the brace isn't bionic. It's not suddenly springing them further forwards. It's just giving them more confidence so they're able to push themselves more. Quadriceps and hamstring strength also show that the bracing increased quad strength. Again, counterintuitive perhaps with some people who think about bracing as again being linked with muscle atrophy. It's not. This will increase the quad strength. If we're increasing quad strength, that's going to again help somebody become a coper. So reducing kinesiophobia levels, increasing quad strength, we are pushing these people towards being copers. So any non-copers could benefit. Global rate of change also shows significantly better knee function. Okay, now we're going to think about the brain, because what we are doing here with bracing and taping is we're messing with people's brains, because we're giving sensation into the skin. And if you have a brace or put a tape on and you do a squat, you can feel stretch on your skin. If you can feel that stretch in your skin, then that means your sensory cortex must have picked it up, otherwise you wouldn't have noticed. Your sensory cortex will talk to the motor cortex. Motor cortex will use every ounce of information that it has available to it to change the movement. And we can play a game. Those of you that are standing at the back, I'm now going to get you to think about your feet, and you now realise your feet are hurting because you're standing. And you've been standing now while I've been talking for around about 45 minutes. So you are now bringing that to the conscious part of your brain. So we can change the levels of our conscious versus unconscious part of the brain. Okay. So conscious versus unconscious. This is a really, really interesting series of studies. It started really with this paper in 2015 in JOSPT, so Journal of Orthopedics and Sports Physical Therapy. And this particular paper looked at two ways of doing tasks. We had the same task, or they had the same task, but they had different instructions. So here we have a single, where's the mousey? We have a single leg stance, keep your balance, stabilizing your body. So we're getting the person to think about their body. Or keep a horizontal bar level. I will show you the horizontal bar in a second. Squat, stand on one leg and bend your knee while keeping your knee over your foot. You're getting to think about their knee, thinking about their foot. This is conscious. But equally, if we have stand on one leg and slowly move towards a cone. And this is the two tasks that they're describing. If we do it with the tasks, with the instructions on the right, we speed up recovery. We get faster recovery. We're getting the patient to think about an external focus of attention. So if you use external focus of attention, this is now bringing in or using the unconscious part of the brain, which means we're making it robust under a game situation, because it's unconscious. If we get people, oh, you've got to think about your knee, where is your knee over your foot? And you try and think about where your knee is over the foot when you've got a 20 stone forward running towards you and you're my size, then you know, it's not your knee over your foot that you ought to be worried about, it's the fact you're about to be crushed. So you have to have this unconscious. So this really, it was one of the key papers to start with this, and they showed a far better recovery with doing exactly the same task with different instructions. So this is something, again, is training the brain. So focus on movement with an external focus of attention promotes the utilization of unconscious processes. When we focus on the movement itself, we are now focusing on, with an internal focus, we're conscious of our movements. And the non-copers are thinking about their movement all the time. We need to move them to be not thinking about their movement. So conscious process, in essence, interferes, mucks up the whole automatic processing. So if I now tell you when you leave this room and you go downstairs, I now want you to think about going down every single step and think about what your knee is doing. You'll probably fall down the stairs. So don't do it. If you just walk down the stairs, you're doing it unconsciously. So it's really important. So the adoption of external focus of attention within rehabilitation is doing the same parts of, or dealing with the same parts of the brain as we are with bracing and taping. We're dealing with unconscious pathways. The final thing I want to talk about is motor unit recruitment. Because when we are trying to rehabilitate somebody and they have got, and they're non-copers, and they've got all their quadriceps avoidance, then we're going to get very, very, very poor motor unit recruitment. So what we're wanting to do with motor unit recruitment, here we go, here's a one pulse going down, and then we have multiple pulses, and we have the motor unit firing. Okay, and we get the build of the tectonic force. So what we're wanting on the left here is the motor units firing, is thinking about getting more and more motor units recruited. Now, if we're thinking about large muscles, say vastus lateralis, when we think about motor units, which is obviously the motor neuron as well as the muscle fibers, we have around about 600 motor units in vastus lateralis. How many are we actually recruiting when we're actually moving? So this is where the idea of using neuromuscular electrical stimulation to increase the motor unit recruitment. But if we just have somebody sitting there in a chair and you put neuromuscular electrical stimulation on, you're zapping the person, well, you might well at that time be recruiting the motor units when you're doing it. Now, it might well have a bearing of increasing muscle bulk, but it'll have no bearing on control. So what has been shown is that when we have neuromuscular electrical stimulation superimposed onto voluntary contractions, which is now, all through the literature, has now been called NMES+. So NMES+ is where we are going to try and improve the way the brain is recruiting the motor units. So we're going to do the task whilst getting the stimulation. So the brain now kind of recognizes, hey, there's loads of motor units which are available here. So we're retraining the brain with neuromuscular electrical stimulation. So this whole idea of cortical activation excitation can be useful. So we've got spinal and cortical levels, passive stimulation versus voluntary exercise. Well, if we have passive, we don't get the effect. If we have the implementation of NMES with the muscle stim, with the movements, then we get improvements. So NMES superimposed with the movements after ACL surgery can have some really positive effects. So this is a fairly recent paper here where they had quadriceps weakness, asymmetrical load, which are both issues of invasive reconstruction. They had a 6-week program of NMES superimposed with repeated sit-to-stand, stand-to-sit tasks. So we're now having the stand-to-sit-to-stand tasks, putting the muscle stim on, doing these tasks. So we're involving the brain, but we're also supplementing or getting more motor units active. And then we are going to have less issue with quadriceps avoidance because we are building up that muscle strength. So this has shown that the NMES plus sit-to-stand, stand-to-sit task showed higher proportion of muscle strength than the extensors, which was accompanied by lower pain levels, improvements in symmetry, which are all those return to sport criteria which the Oslo, Delaware studies have been talking about for many years. So when we incorporate NMES with these repeated sit-to-stand tasks, we are going to recover our quadriceps strength better. And again, if you're thinking about our non-copers, this will help those non-copers. So there has been some work done about coper classification, and in this case we've got 300 athletes enrolled. Initially 55% were identified as potential copers and 45% as potential non-copers. We still have to use the word potential because we don't have quite the robustness in the prediction yet, but there's a lot of work going on here, predictive criteria for copers and non-copers. After 10 sessions of neuromuscular and strength training program, nearly half of the non-copers became copers. So a non-coper can become a coper if we are targeting the aspects which the non-copers present with, which is high levels of kinesiophobia. So what can we do with that? They have poor quad strength because they have quadriceps avoidance, not because the muscles are suddenly weak, they're just not using them. Copers increased while non-copers decreased. Dynamic stability improved after the training program, but there were still some persistent non-copers that continued to fare poorly. So what else do we want to do with those? Well, in this particular study, which all fits with part of the, these are still the same authors within the Oslo, Delaware, if you remember the earlier slides. So we can still think about doing more. So the ones that really don't respond, then what do we do? What do we do to escalate? Are they the ones we're wanting to escalate with NMES plus? Are they the ones we're wanting to escalate with bracing or with other ways of overcoming kinesiophobia? But we need to know the kinesiophobia levels. So bringing kinesiophobia assessment into your clinical arsenal, I think, is a very, very quick and effective way of working out whether or not somebody is or isn't being a non-responder or a non-coper because of those factors. So we need clear identification of the non-copers, or spelled copers wrong there, considering targeted interventions. So, in conclusion, we want interventions which are going to give mechanical stability to protect growth. We're wanting to bring in rehabilitation tasks or interventions which are going to help the unconscious aspects of control. So these could be bracing, it could be considering the external focus of attention tasks. We could bring in interventions to increase the motor unit recruitment. So we are now giving the brain more to work with when we are dealing with the control. So all of these, I think, have got particular use, in particular when we have the non-copers. So thank you very much for listening, and thank you very much for taking the time during a very busy day. Thank you.
Thank you so much, Professor Jim Richards, for your very interesting presentation. And I would also like to welcome another panelist, Jimmy Reynolds from Alpha Physiotherapy, to join us in the Q&A. So, yeah, Jimmy has been regarded as one of the top physiotherapists for ACL injury management. So it's very interesting that to have both of you here. So Jimmy, your recent ACL webinar with Enovis UK on enhancing outcome in female ACL rehabilitation, you mentioned that ACL injury is a brain injury, which was really fascinating. So could you elaborate more for us and related to today's non-copper topic?
I think, well, thank you very much for having me. Fantastic presentation, and it's brilliant. I think it echoes kind of exactly what my presentation was on before as well, which is that we typically would think of an ACL injury as a very mechanical. I have a failure of a ligament, and if I repair that ligament, everything will return to normal. It simply doesn't work like that. We would love it to, and it would make our life a hell of a lot easier. However, ultimately, our anterior cruciate ligament is highly sensitive. It's got a huge amount of innervation. And as soon as we rupture that ACL, all of a sudden, it's like turning off the switch in the brain. There's no longer any afferent signals that head up to the brain. There's nothing coming back down. So all of a sudden, our sensory cortexes in our brain have lost that ACL. So our knee suddenly becomes, in essence, slightly numb to the brain. So in essence, when we first have that injury, and it starts from that point, immediately after having it ruptured, the brain starts to lose that innervation to that area of the brain. So in essence, not only do we have a ligament that's no longer providing information up, the brain isn't able to find the information to go down either. So we instantly think that, okay, well, let's repair that ligament and all will be right. However, mechanically, we repair that ligament. We put a new one in. However, we don't repair the nervous system. And I think this presentation highlights that fantastically, because we've gone from having a highly organized nervous system that can control the knee. Whether it can control it very well or not is a different question. But all of a sudden, we're in a situation where we don't have any nervous system input to that area. So we have to go through changes, and we have to relearn how the body can move. And I think this is really starting to be highlighted, particularly in the world of female football, which is obviously hitting the news pretty much internationally about the number of ACL ruptures. And again, the first thing that we all do is look at mechanically, and it must be the body shape, and it must be aspects of the pitch or something different like that. However, there's still this big question of neurologically, are we well prior to the injury able to cope with it, but also after having the injury, do we rehabilitate people to have that efficiency in their brain again? And this slide that I put in the presentation was a really fascinating one. I think it came from the Dustin Groom group in America, which they looked at effectively brain efficiency. So the image on the right was someone standing on one leg. So you had three different people. So one was someone who was competent at karate, one was a fencer, and then also non-athletes. And what you could see was the density of the activation within the motor cortexes within their brain. It was drastically different between their abilities. So you have people who are very efficient movers and practiced and are used to doing a movement, become very effective in their brain. They use less of their brain, so it's more efficient. However, as soon as you rupture that ACL, what they believe now is that you go from having that very efficient brain to actually being a non-athlete again. You can no longer find your nervous system activation.
Yeah, it's really fascinating. So Professor Richards, we know that you have been using that brain animation for all your ACL presentation. And you used to ask the question, so you said, all in our brain. What's your position? What's your position now?
Well, I mean, obviously there is some mechanical stability the ACL also provides. But there has been an overemphasis on you know, the magic repair of an ACL and all is well. So I totally agree with Jimmy there. So we have to have this neuromuscular control thinking when we're doing our rehabilitation. You know, what are the best rehab exercises, for instance? How do we get that movement and movement variability into the rehabilitation, so the brain has a chance in a safe environment to relearn motor control? But it's so important that this is done on the unconscious level of control rather than the conscious. And I always draw the analogy of, you know, get somebody to walk downstairs and get them to think about walking downstairs, and you massively increase the chances of them falling. So the conscious part of the brain is pretty poor at controlling movement, whereas the unconscious part of the brain is fantastic at controlling movement. So there's an element there, and this is where kinesiophobia is also clearly, obviously, involves the brain, psychological, but that will also interfere with those pathways, because in having a fear of movement, then the person will be basically bringing the movement into the conscious part of the brain, which actually makes them more at risk. So those people with high levels of kinesiophobia are thinking about their movement far too much, and therefore probably putting themselves at greater risk. Well, one question I do have for Jimmy actually is if I am allowed.
Sure.
One of the things that we notice, and I'm sure that you've seen yourself, is the unaffected side becoming worse in terms of its motor control. One of the things I've always, I guess, brought into conversations is whether or not this is because the brain doesn't like asymmetry of information that it gets from the rest of the body. And if the brain doesn't like asymmetry of the information, it will, in essence, even though you've still got an intact ACL on the unaffected side, the brain is in essence ignoring the information from that organ because it can't see it on the other side anymore because it's been ruptured. That's always been a little bit of an explanation I've used, but I'm just wondering whether that fits with your experiences.
I think clinically it does. And I think you also have to consider when you bring in the copers and the non-copers, I think the best copers are able to implicitly almost ignore the fact that they've had an injury. I think they're very good at cognitively moving on. They recognize there's a rehabilitation process and they move on very quickly, whereas a non-coper tends to have that over-analysis of a situation. So kinesiophobia obviously being a huge part of that. So clinically, when I look at a coper and a non-coper, I can certainly see there's a difference. And when you then go through the rehabilitation process, often the copers, it's very easy, it's very smooth. They pick up exercises, they pick up rehabilitation very quickly. So their ability to almost access their movement habits, their movement patterns seems to be translational left to right. It's not like, I don't often see kind of a drastic difference between, right, oh, you know, we're really struggling or we're really working on the good side, but the bad side's really slow. Actually, they often follow suit pretty quickly. And I think activation-wise, they follow suit pretty quickly. So, for example, even if you just looked at pure strength, I think you would often find there's a gradual increase on left and right side equally. I think for the non-copers, and when they really do struggle, and I think this is where a lot of the research is going to go, I think, is you can almost relate this to a chronic pain situation whereby you put in both a psychological factor, you put in a physical factor and a pain stimulus and an experience of pain or an experience of immobility. And all of a sudden you have, much like in kind of the biopsychosocial approach of chronic pain, you've got someone who, it's a very complex creature now that you're having to deal with. And it's not just the physical side of things. So I agree with you. I think that we'll often see these people be quite confused, in essence, both from a motor perspective in terms of how they move, but also from how they feel about how they move at the same time. So I agree. It's not a simple picture, absolutely, but I do agree. There's definitely this element of the brain kind of losing its way, in essence.
Interesting. Thank you. Thank you. So the second question, so Jimmy, you mentioned you use the NMES throughout the rehab phases to improve that neural efficiency. So could you also elaborate on that? Yeah.
So the classic effect of having not just the ACL rupture, but even post-surgery is that arthrogenic muscle inhibition. So we very simply look at that as a knockoff of the nervous system. The nervous system doesn't work as efficiently. But again, we have to think of it from a top-down perspective, so from the brain down through to that area, as well as from the muscle and the joint effect higher up. So utilizing that neuromuscular stimulation has been a staple of ours for many years now. from both a localized effect, which is to increase motor unit activation, which ultimately is the aim to increase muscle hypertrophy and strength overall, but also the sensory feedback with it as well at the same time. I don't know if many people here have used a muscle stim, but when you use it and you put it on very high, it's incredibly uncomfortable initially. I think if anyone's aware of Neymar, the Brazilian footballer who's just had his ACL reconstructed, you can see some videos of him kind of screaming out in pain as he's doing various different neuromuscular stimulations. Perhaps his perception of pain is slightly different, which is why he is feeling it a little bit more than others, perhaps. But we use it from both a motor perspective as well as a sensory perspective, from a bottom-up and a top-down effect on the nervous system. We will use it consistently. We will use it every single day, often 2 to 3 times a day, and we will start to utilize it in functional movements at the same time. It's really the first 8 to 12 weeks that we absolutely gun this, and we will use this heavily. And then as we start to change the rehabilitation environment, as they move on, we may start to move away because we find other ways of increasing that muscle activation.
Right. Yes. So interesting, because in Asia, most of the, muscle stim is now getting very popular for ACL rehab, but because it's called muscle stim, so I think in the MSK world, people tend to use it focusing only on the muscle. But you in your webinar, you're describing it as improving neural efficiency, and it's very interesting because in Enovis we do have devices which are functional ES, FES, which in the neuro rehab world we use the language. This is a neuromodulator, neuroplasticity. And that's their language. That's the standard term. But when we are in MSK, when we try to apply the same concept, but the MSK guys will say that's neuro rehab.
Yeah, I think that's a really good point. I think that a lot of the time that it's that separation of a neurological physiotherapist, for example, and a musculoskeletal, when actually it's a neuromusculoskeletal. It's the whole package. And I do think that sometimes in a sports medicine world, especially, we remove ourselves neurologically. I think when actually it's the same principle underlying. It's all movement. And much like in the chronic pain world, you'll get more by teaching someone how to do a movement than you will by activating a muscle. So it's as Jim was saying in that presentation, it's making it implicit, and the difference between how we learn tasks, implicit, explicit, is okay. Well, if I do a direct thing and if A plus B equals C, that's one way of learning. However, if I have a challenging environment which achieves the same movement, I'm going to learn more. It activates different parts of the brain. So I think that separation of muscular when it's actually neuromuscular, if we go down into the physiology of it, we're all doing the same thing. The difference in neurological rehabilitation is they may have had a brain accident, there may have been a bleed, there may have been a stroke, for example. They're having a top-down effect, whereas actually, are we having a bottom-up effect, or are we having both?
Yeah, thank you. I'm so glad that now I have a MSK guy talking about neural effect. And Professor Richards, how do you think how we can more bring in the neuromodulation concept into the MSK world?
I mean, I have to say I was smiling all the way through that. So it's interesting because one of the ways that we can perhaps bring the language in, because it's partly the language which I think the MSK physios are not necessarily comfortable with. But what we're describing is motor control. And if we have a motor control philosophy to this within our MSK rehabilitation, then that might be, dare I say, an easier sell to the MSK physio, because they'll understand that they're trying to improve movement control because they are wanting better quality of movement, and that term quality of movement is throughout both MSK and neuro physiotherapy, I would say. It also very much links with the way that we are now starting to use other methods of analysis of movement, and that's through EMG. So using EMG to measure muscle activity, previously we'd be thinking about EMG as a measurement of what the muscle is doing. Well, the muscle won't be doing anything unless the brain tells it to. So what we're in essence measuring is control signals into the muscle which have come from the central nervous system, and sometimes from reflex arcs, but majority for what we're describing is from the central nervous system. So I think there is a move, but I think that there is elements of language that we can perhaps use when describing within MSK context. As I say, I tend to talk quite a bit about motor control and improvements of motor control, which are obviously going to prevent re-injury if we are focusing on things like ACL injuries. So I think that's one direction or one way in. But as you say, Jimmy, I mean it isn't musculoskeletal, it's neuromuscular, but unpacking what that means and what assessments that we can do to determine whether or not we've got recruitment or non-recruitment of muscles. This is where we have got advances in technology to do more measurements, certainly in the research context, to support these philosophies and to bring more evidence forwards for the effectiveness and efficacy of rehabilitation exercises.
Okay, great. So a lot of people ask for good exercises of ACL rehab, but I think in the limited time, I would highly recommend that you follow Jimmy's Instagram. He has lots and lots of good exercise for ACL, customized, individualized, and also make sure that you also watch that the webinar that we just showed recently broadcasted on Enovis UK YouTube channel. And so the next question we really want to touch on is return to sport criteria. Also a lot of questions on that. And that's also the reason that we put in the poll question, kinesiophobia, psychological readiness. So Jimmy, very interesting, you said you do all these assessments on return to sport criteria. And yet you said ultimately the decision of returning to sport is a psychological decision.
It is. Yeah, I mean, certainly I've got a background of working in elite sport, and when you're working with these people who are trying to get back to high level sport, there's obviously a huge amount of pressure that drives into psychological pressures that is self-imposed, but also externally as well. There's certain markers that you go through, like with any ACL rehabilitation, which is very mechanical. So I may do strength testing, isokinetic dynamometry. I may do rate of force development, power, reaction, agility. So really the physical side of things. What we most commonly see, though, is people can achieve that quite quickly. They can achieve that even as early as 6 months, 9 months. But we know that the success in returning is actually in the longevity, is actually taking that extra time and doing those extra months, and a minimum of 12 months. Now, usually what we find is that by anywhere between 9 to 12 months, we might be moving back to an outdoor environment. They may be back on the periphery of team training, for example, if it's a multi-directional team sport. But the confidence comes from repetition and consistency in their outdoor training. What we most commonly see is fear is the big thing that holds people back. The fear of the big tackle, the fear of the game environment, the fear of the external things around them, taking that physical contact. So we have to expose them consistently. We have to be creative with that. And I had a really good example of one who was a professional football player who was ready by kind of 11, 12 months, passed all the key criteria. But the thing holding her back was her fear. And we actually took another 4 months of consistent training before she accepted that she wanted to play in a game. The most important part of this is working closely with that team, if you can, if you're able to work with the coaches and educate them so that they can understand. Because for them, sometimes it's, oh, we must be fit. You've passed all these tests. actually, no, we're still not psychologically ready. So from my perspective, that's almost one of the last criteria that we want to tick off. We're going to work on it throughout the whole rehab. But if we can highlight that and we can put together various different ways of them being able to psychologically cope and build their confidence, be creative, consistent and repetitive in their rehabilitation, then psychologically, that will be the final thing that we tick off. Equally, we can have it the other way, where people are so psychologically ready that they're not physically ready yet. So those are the ones that you get people like us going, whoa, 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 slow right down. I'm going to be the one putting the stoppers on now. And equally, they're a different challenge at the same time.
Right. Yeah. So also many audience ask about future technology, biomechanic research on ACL rehab. And Jimmy, you mentioned the outcome measurements, technology outcome measurement. So do you guys see more technology outcome measurement on today, what we discussed, neuroefficiency, psychological readiness being more available in the future?
I think so. I think we're getting there, but it is getting there slowly in the practitioner's field. So I think from a strength testing perspective, from a power, from a rate of force development, force plate technology, for example, has become very available now. There's companies around the world that are really pumping this out, relatively affordable now. An isokinetic dynamometer is still quite drastically expensive. So I would suggest linking up with the university if you're going to do something like that. But what I think we have to remember is you can test, for example, we could do a jump test, and that may give us some scores of power, rate of force development. But that is only testing that test. The key thing is actually we need to come up with various tasks that we test people with, that we then have a period of rest or a time away from, and then we retest again. So we look at that brain efficiency of retaining information. I can do an isolated knee extension and go, I've got a great level of strength. But if someone shouts at me and really annoys me and I'm very sad, actually that may impact my outcome next time. So we have to have probably a greater emphasis on applying repeated tests over time, I think, which is really what we've done, certainly in the world of sport. You're able to do this on a daily basis during training sessions, different drills, repetition, till it all becomes very subconscious. And then the psychological outcome measures is probably the big thing that we should then be sitting back on. So like the Tampa scale, and then also things like the ACLR SI, the Return to Sport Injury Index. That's a nice, quick, simple one to put into place as well. That's
great. And Professor Richards?
Yeah, so the development of more ecologically valid testing, I think, and so there's certainly ways of doing this within more of a real world environment. I mean, moving outside of the lab is what we're trying to do most of the time these days. There's still things that we would do within a lab setting. So I mean, one of the things which is throughout ACL literature is the LESS score, the landing error score, and the LESS score is in essence a double limb jump, and then you land, and then you do a jump again, and then you land, and you assess on the second landing. And I can't think of many sports where you would land with both feet at exactly the same time. So it's not really a particularly relevant. So looking at the thing that's good about the LESS score is there are clear criteria for scoring. So it's a good way of getting something which is scoring, but the activity, I would say, is not necessarily ecologically valid. It certainly doesn't have much association with sports-related movement tasks. So developing new assessment tasks that which are valid, repeatable, all of that sort of thing is absolutely critical to go forward, that can be easily implemented within a sports specific environment or a clinical environment is a direction of travel. So there's definitely technology in there to further refine the assessments that we're doing. In terms of recording, I mean, force plates, as Jimmy said, is a direction of travel. We are doing an awful lot of work with inertial measurement units, IMUs, which are even cheaper than force plates. So we've been doing a lot of work where we're looking at dynamic stability. Let's take, for instance, the Y balance test. And then we think about what the Y balance test will actually assess. And the Y balance test, if we are being really honest, will measure how far somebody can push a block and very little else. But if you start to then look at the dynamic stability of somebody while they're doing that task, you can then get measurements of stability whilst they're doing that task. So we are using IMUs regularly now on all of our Y balance testing. These are, as I say, reasonably low cost. And it will allow us to then determine whether or not somebody is performing well by pushing the block further, but how stable are they while they're doing it? Because if they're unstable, then that's going to be one of the risk factors, obviously for any re-injury, regardless of whether it's ACL or another type of injury. We're commonly doing this with chronic ankle instability, for instance. So I think there's two areas that we need further development of, which is currently going on, and one is getting more sport-specific tests that we can score reasonably easily and reasonably reliably, which will allow us to monitor progression during tasks which are relevant. And the other is the use of technology to further improve the assessment itself. But you know, if you're bringing a biomechanics perspective to this, there's so many things we can measure, and that doesn't help. You know, what we need is one or two measures that are sensitive and appropriate and relevant. And if we have that, then we really cut down the work that needs to be done by the therapist, by the person doing the assessment, because we have clearer identification of the things that are A, important, and B, sensitive, using that technology. So I think there's some reductionism that needs to happen. But based on technology data that we have for technology, but then to reduce it. Some people at this point then you use the dreaded letters AI at me, at which point I think that I would prefer to apply some real intelligence to this first, to make sure that we get things which are meaningful, that we understand, before starting to go to artificial intelligence options. So we're doing a lot of work drilling down on this. As I say, development of more appropriate assessments, developing the technology to aid those more appropriate assessments is the direction of travel that we're certainly going in.
Okay, great. So looking forward, to new technology.
Oh, you're on mute, Crystal.
I'm not. Hello, can you hear me?
I can't hear you.
Yeah.
I can hear you.
The final question is since now it's a ski season again, and the last ski season just first one post-COVID.
Still can't hear you. Well, I can't.
Hello. Can you hear me now, Jim?
I can hear you.
Okay. Yeah.
Is
so
it just me?
It may just be Jim.
Sorry, Jim. So the question is, do you have any advice how to prevent ski injury? Because it's now a ski season, many people are preparing for their ski holiday. So in particular, for somebody who had a prior injury, that's first. And then secondly, for adolescent who had a prior injury. Jimmy,
So
what's your advice?
Yeah, no, I think this is something we see pretty consistently in our clinics. Is someone goes through the whole year not doing, say, much exercise, and then all of a sudden decides to go on a skiing trip, which is going to physically overload their body for the first time all year, perhaps. There's a couple of things we look at from a preventative perspective. We do recommend bracing. So we do use the Enovis and the DonJoy bracing, so particularly the armor. We would often move towards that. Design for skiers is robust, it's rigid, prevents that translation. We often have people coming in to have an assessment to see whether it's suitable for them, and they often end up having one on each knee because they look at it and think, actually, I'd just rather not have any risk at all of doing my ACL, particularly if they're in a normal job whereby they're going to need to be physically active afterwards, so they want to minimize their risk. So bracing is the first thing that we would often look at, but even prior to that, we want to make sure that they've got that adequate strength and they've got that neuromuscular control. So we may go through, or we'll encourage them to go through a period of exercise prior to that, because ultimately they're going to be on their feet every day, perhaps whilst they're skiing if the snow's good, and they're going to want to be out there as much as they can. So we need to increase their kind of workload capacity, so quadriceps, hamstrings, glutes, trunk, their abdominal control for the whole body, really, to minimize every possible risk we can as best as we can.
Oh, thank you. And Professor Richards, can you hear me now?
I can hear you now, but I missed the beginning of the question. I do apologize.
No problem. So question is, any advice for the people who are going to ski, because it's a ski season now, and especially adolescent that we mentioned the retear rate of who had an ACL reconstruction is twice as high as average.
Okay, so yeah, I caught some of Jimmy's answer. So I think yes, I would certainly agree. You know, that the concept of, you know, if somebody is feeling they need it, the bilateral bracing, with obviously working all the getting the muscles working, I think is absolutely critical. So I don't think I can add much to the answer that I heard from Jimmy.
Okay, so yeah, so that's a question. We answered all the questions, and so we do, as I mentioned, that we do have a ACL management brochure covering the Coper non-Coper topic, as well as conservative management, which you can download from our website. So the link is shared to everybody in the chat room. So this you can access from the chat room or scan the QR code. And also that we do have a Learn Up On platform, which you can do online courses. There's for example, this is one that the courses are about Professor Jim Richards, biomechanics of ACL injury. And we also have, for the physiotherapists here, we also have shockwave certificate courses, high power laser certificate courses. And I think more than 6,000 healthcare professionals around the world are already registered into the Enovis Institute Learn Up On system. And you will get a certificate immediately after you finish the courses. So you are very welcome to access. So you can also book a one-on-one demo practical training session with a local Enovis representative. So please, you can fill in the survey after the webinar, and our representative will be in contact with you. And so thank you all for joining this very interesting and very informative webinar. And we look forward to seeing you in the future webinar. Thank you. Thank you all. Bye. Thank you, Professor Richards. Thank you, Jimmy, again.